So, good morning, everyone. Today, Bhanu will be presenting the case. It is moderated by Professor Puneet, Dhar, Professor Venkatrami, Reddy, and myself, and other faculty can join in as well. Okay, now it's all yours. Bhanu, you can go ahead.
Very good morning, sir. I'm going to present my case here till now. This is regarding this is a 29-year-old male patient, sir, who is a resident of Telangana, software engineer by occupation, who came with the chief complaint of recurrent episodes of flu stools with blood and mucus associated with abdominal pain in the last 6 years, with history of loss of weight in the past 6 years also. So, patient was apparently normal, all right, 6 years back, when he started developing complaints of 4 to 5 episodes of small quantity, non-foul smelling, semi-solid loose stools mixed with blood and mucus since last 2 months. Associated with complaints of intermittent lower abdominal, crampy abdominal pain. And there was history of loss of weight of approximately 3 kgs in the initial 2 months. There was no history of fever at that time. At that time, patient was evaluated elsewhere and hospitalized. He underwent colonoscopy and biopsy. He was then given few injectable medications, following which his symptoms improved and patient was discharged on oral medication. He regularly continued medications for 2 months and stopped in view of resolution of symptoms. After that, for the next 5 years, he was symptom free. But then again, he had a recurrence of similar episodes for which he was evaluated only in the OPD. No admission was done. And he was started on oral medications which were gradually tapered and then stopped and was advised alternate oral medications here. But he stopped his own medications on his own after 2 months as the symptoms relieved, and he was asymptomatic for next few months. In February 2024, he again had a relapse with 7 to 8 episodes of bloody diarrhea and abdominal pain, for which he was required hospitalization, and he was re-evaluated with colonoscopy and biopsy. Colonoscopy. At that time, he was given few injectable medications. 2 doses were given about 2 weeks apart. Could be biological, and frequency of stools have decreased from 7 to 8 episodes to around 4 to 5 episodes. But he continued to have some abdominal pain and bloody stools also. He was advised to continue previous oral medications. However, his symptoms gradually worsened, and he developed 8 to 10 episodes of small quantity semi-solid stools, which are non-foul smelling, mixed with blood and mucus, associated with nocturnal defecation since last 1.5 months. He also had tenesmus and urgency history also. Along with this bloody and mucus mixed diarrhea, patient had associated hypogastric crampy abdominal pain, which aggravates after food and not associated with nausea, vomiting, or abdominal distension. Here, I want to know whether it got relieved after passing stools. Patient gives history of low grade fever and history of significant weight loss around 10 kgs in 2 years, and history of 2 points of PRBC in the last 1 month. There was no history of loss of appetite or fecal incontinence or dysuria. No history of intolerance to milk or milk products. No history of any joint pain, backache, jaundice, skin lesions, ocular complaints like extraintestinal manifestation. No history of any periannual discharge, mark for rectum or incontinence. No history of skin lesions or redness of eye. Again, with respect to extraintestinal manifestations. Past history, patient doesn't give any history of any previous comorbidities or any previous surgeries. Personal history, he is unmarried, consumes mixed diet, appetite is adequate, disturbed sleep in last 1 month due to nocturnal defecation. And he was a known alcohol, he was used to consume alcohol for about 360 ml per month, but stopped since last 2 years, and is a repeat smoker. He consumed for 10 years around 1 pack over 2 to 3 days, but stopped in 2018. Since last 6 years, he has stopped smoking. No significant family history. So to summarize, it's a 29 years old young male patient who is unmarried with no comorbid illness presented had with complaints of frequent passage of blood and mucus mixed semi-solid stools associated with crampy abdominal pain for the 6 years. He got treatment with IV injectables, steroids, and mostly biologicals also, for which he had and relapses. Now he is having worsening of symptoms with increased frequency, around 8 to 10 episodes of bloody diarrhea and crampy abdominal pain. But he doesn't give any issue of severe pain abdomen or high grade fever or obstruction symptoms for now. So my most probable differential diagnosis would be inflammatory bowel disease. Now, active, moderate to severe intensity.
Which inflammatory bowel disease? Tuberculosis?
No, sir. Ulcerative colitis is most probable. It is most probable ulcerative colitis because bloody and mucus discharge diarrhea is more commonly seen in ulcerative colitis. And also, according to the history, he was had repeat colonoscopies and biopsies and was treated with IV injectables for which he was having remissions.
So it's not a good idea to use the diagnostic tools as your points to support diagnosis. Give the hard, the order of importance you should keep is for objective science first, which we have none, except, it's all historical, but there's substantial in the history that, you can give a diagnosis straight away. A long history, so you should stress all the points which support your diagnosis in the history. Saying that colonoscopy for Crohn's, you don't do colonoscopy?
We do, sir. We should do.
For
We do.
TB, you won't do. For eosinophilic colitis, you won't do. So it doesn't
Yeah,
tell
any
us. It doesn't
colitis
tell
we
us.
have to do, sir.
So when you're asked to pinpoint why you're saying supporting, give all. There's so many things in the history. Sharp, remitting, relapsing, sharp remissions and relapses. He's okay. He's himself actually stopped the medication each time. Normally it is the doctor who has to reduce it. So I notice you guys use a lot of investigations because he's had an endoscopy and it stopped something, so it is a varices. So don't use that as a diagnostic tool as saying, oh, I can only reduce by this. This session is to test your clinical skills, so use that. What do you think is the relation of smoking with this particular illness?
Smoking
It was highlighted also.
Yes, sir. Smoking is usually protective in ulcerative colitis, sir.
By protective, you mean? Should you start smoking? Give nicotine
No,
patches? Any evidence for that?
No, sir. It shows patients who are smokers have a lesser severity of ulcerative colitis.
Active smokers actually have less ulcerative colitis. So typically when they give up, it can actually, the onset is very frequently. So you can see this patient has given up in 2008. Yeah, and exactly the same time. So very well. How does it correlate with Crohn's?
Crohn's is usually smoking deteriorates. It's anti.
Yeah, actually stopping smoking will help in getting a relapse. Getting a remission. Yeah. Okay. So you said no severe acute abdominal pain. What did you want to?
No, sir. I mean, the patient is not having any acute abdomen as of now, like severe abdominal pain or abdominal distension or obstructive symptoms, or to rule out any acute condition. He's having acute colitis because still the frequency of stools are 8 to 10 episodes per day.
So you mean he doesn't have an acute condition? I didn't get that. What are you trying to imply? So for instance, you could say that he's not had any acute episodes. That might how is that important?
The patient is any acute severe colitis or fulminant colitis history.
So acute severe colitis and fulminant colitis is by pain? I mean, if you have severe abdominal pain, what all will you think of?
Obstruction.
In such a case, Yeah. So how common is
obstruction,
obstruction in
perforation.
ulcerative colitis?
It's rare, sir, unless it's stricturized
It's
or it's
almost
a
never there. Yeah,
malignant.
it's almost never there. If you have get a stricture, what do you? It's almost the a fibrotic stricture in the absence of malignancy is extremely rare. Extremely rare. You almost never make a diagnosis. So it could actually favor Crohn's. So if you
Ulcerative
say
colitis.
that, yeah, then we know what you're talking about, isn't it? It could actually favor Crohn's if you're having recurrent abdominal pain. But
Yes,
what
sir.
else can? What other thing can be with acute pain? You said distension as well.
Toxic megacolon can present with
Yeah, so
acute pain
that
and systemic toxicity.
yeah, so you specifically said this time he doesn't have, but it might be important to look for history of recurrent history of megacolon because that might alter your diagnosis of just tell us in history and what all are you looking for in a case of ulcerative colitis? What historical points of importance will help you in management? So, part one
So
is to make the history, the diagnosis, but what all points will help you? Very important to elicit right now.
main is duration of disease, sir. For
Why?
how many years, sir?
Why?
Because as if they increase more than 8 years or 10 years of duration, there's a high chance of malignancy risk is there. So that we have to keep in mind. And it, with diagnosis also it helps in the based on the duration also, and based on the episodes of relapses. The patient treated with only oral medications or patient required any IV injectables like steroids or biologicals. It means the patient is having a severe disease, which increase the chance of colectomy in future. And we will know that if the patient was treated already with IV steroids and biologicals not responding, then we know that patient might not respond to other modes of medical treatment. And
Okay, Dr. Sadik
we
has
should see
written.
it.
Yeah, he's written in the chat box. What about the history of significant weight loss, urgency, and tenesmus recently?
Yes, sir. Weight loss is there since 6 years. The weight loss is there, sir. So, but tenesmus and urgency is recent. He has mentioned only recently. So rectal symptoms, tenesmus and urgency are more of rectal symptoms, and if there's any um, even with proctitis also we get tenesmus urgency. We should keep in our back of mind whether any there's a malignancy is very rare right now, but we have to keep in our back of mind.
So you can have all these symptoms in ulcerative colitis. It's a recent history that should make you suspicious, isn't it?
Okay.
So you can have through a weight loss, or loss of all the nutrients, all that. So, but
Any
when it's an
recent change
acute,
in
yeah, you need to be worried. Okay, urgency and tenesmus should start actually. The episode should start. Each episode should start with that because proctitis is there in what percentage of cases?
proctitis is there in all
Not all,
almost
95%. Okay,
95
95% of cases, 5%, 5 to 10% can have rectal
rectal
sparing.
sparing.
Yeah. Rectal sparing is very, very important. Why? So that's another point of you need to take in the history. Do you have rectal predominant symptoms? How will it change your management?
Surgical options, if we are planning for surgery, surgical options will vary. Whether to do total colectomy or proctocolectomy, we can decide based on the rectal symptoms and disease index.
Especially in the elderly who present to you with a long history and sparing of the disease in the rectum, you might think of, or extremely young who are paranoid about
Not that
conceiving fertility. Yeah, you might consider, but only in those cases who have rectal sparing will you consider it. Okay. Pradeep, Dr. Reddy.
Yeah. Go ahead,
We'll-
Reddy.
Yeah, we'll go ahead with the examination. Yes, sir.
Yeah, before that, can we confidently say it is UC or you still want to have any other differential diagnosis? Because we're not yet examined, you're not know the tests, right?
yes, sir. My first most possible diagnosis is ulcerative colitis, sir. Other possibility can be Crohn's colitis. So these two things I'll keep in mind because of long duration is one thing. One more thing is patient responded to IV medications and then got relapses also with IV medications, remissions with medications.
We don't know what IV medications he received. He just received 2 injections. It might be.
Yeah, might be
How
antibiotics.
can we say that
recurrent.
it is received biologics? We don't know. It's just some 2 injections, right? I don't think it's already decided that it is biologics. We don't know. The patient has not told you that,
Yeah.
right?
Yes, sir. Yes, sir.
Yeah.
Steroids, I think, because they mentioned tapering of dose, maybe
Tapering of the dose happens with what? What drugs?
it happened with steroids or
Yeah. Not with biologics, right?
yes, sir. Steroids. Sir.
Okay. So the other thing is based on this history, suppose if it is an ulcerative colitis, okay, let us take it ulcerative colitis. Can you assess the severity of based on this history? Is it mild, moderate, severe?
Sir, for severity, we require other parameters like lab and uh, tachycardia, these things also. But as of now, because the frequency of episodes is 8 to 10, it is most probably moderate or severe colitis.
Moderate or severe. Okay. Anything else we can go for the examination?
Yeah, we can go, sir.
Yeah, sure.
Sure, go ahead.
Thank you. Coming to general physical examination, patient is conscious, cooperative, well-oriented, moderately built and poorly nourished. Hydration status would be helpful here. BMI is 15. Performance score is good performance score 0. Vitals no tachycardia. Pulse rate is 70, BP 130 by 70. Febrile. Taylor is present. Pedal edema is present. No cyanosis, express clubbing, generalized lymphadenopathy. No supracalcular lymph node. No obvious signs of dehydration. No redness or watering of eyes. Peripheral joints are unremarkable on examination. Inspection per abdominal examination. Inspection abdomen is flat, umbilicus is central and inverted. All quadrants are moving equally with respiration. No signs or engorged veins or pulsation or peristalsis. Hernial orifice normal. No renal angle fullness. Palpation soft and non-tender. Spleen liver not palpable. No other palpable lump noted. Hernia sites are no cough impulse. Liver span 13 centimeters. No hepatomegaly. Plans are tympanic. Auscultation is normal. Bowel sounds are here. Digital rectal examination, normal sphincter tone is seen. Perianal, there's no evidence of any exploration, fissure, fistula, discharge. On glove examination, blood-stained stools are present. In proctoscopy, erythematous rectal mucosa is seen, but no active bleeding is seen. Other system examinations are normal. Respiratory system, CVS and CNS. So this is coming to summary. Is a 29 years old male unmarried patient with disturbed bloody diarrhea and crampy abdominal pain for the last 6 years with remissions and relapses. Now with worsening of symptoms with increased frequency of bloody diarrhea, stools and crampy abdominal pain. On examination, patient is having good performance status with poor nutrition status because of low BMI and fetal edema, and Taylor is present with erythematous mucosa of rectum with no signs of systemic toxicity like hypotension, tachycardia, or fever.
Okay. Anything in the clinical examination? Any difference? Anything you want to change?
In the clinical examination, patient doesn't have any tachycardia or fever or hypotension. So severity of the disease is most likely based on this examination findings could be moderate. There is no dehydration also. There is no dehydration also. On proctoscopy, we could see erythematous mucosa of rectum, but no active bleeding. But the nutrition status is has to be is poor because of low BMI and fetal edema. And pallor is there, first of mostly anemia, low hemoglobin level.
Okay. Yeah. Oh, okay. Nothing much change from your clinical examination. So it's all same.
Yeah.
Yeah.
So basically, it's like a neurology examination, isn't it? In medicine,
Yeah.
mostly we go for the examination findings, but in In ulcerative colitis, it is IBD. It is mostly the history which will tell you a lot. The examination tells you only whether it's elective or emergency. Only thing it can
Yes,
tell
sir.
you is about the fulminant colitis. Most stuff. Anything else specifically in the examination that you can get? In
Any extra intestinal manifestation we can rule out.
why? Yes, why?
If present, like if there's any extra intestinal manifestations, um, like if there's any jaundice, PSC, then severe, the prognosis or severity will be
Really? What is the impact of PSC on ulcerative colitis management?
malignancy risk will be higher.
So
in
malignancy risk is higher. That's all. Does it affect your decision to operate or not?
No, sir.
It might increase your chance of a liver transplant eventually, but does it, as a surgeon, does it make a difference? What extraintestinal manifestations will make a difference to you as a surgeon?
Um,
How do you classify
that
extraintestinal manifestations?
which, which are associated with severity of disease, which are
So what is that called? Yeah, what's the term? Colitis dependent and colitis independent. So apart from the the organ-wise distribution, you must know whether it's colitis dependent. So if you're getting the colitis dependent ones frequently, that might actually alter your indication. Some of them might be an indication by itself.
it is for surgery. Yes, sir. Pyoderma gangrenous, and these resolve with the treatment of ulcerative colitis. So if there's any severe extended manifestation like skin manifestations, it's better. It's one of the indications for surgery.
So we said there were no perianal signs and all that. Why are we looking for those?
Perianal, it's a anus is not involved. It's not involved in ulcerative colitis. If there's any perianal discharge or fissure of fistula, then we should again have a suspicious of Crohn's in our mind. So,
Yeah, as surgeons, we are paranoid about all perianal signs because it takes a decision to do a pouch much more. The chance of it being Crohn's, even a remote chance of being Crohn's, we want to avoid doing a pouch, isn't it?
yes, sir.
Two issues. One, it can alter your diagnosis. It might also your decision for pouch also. It could be non-specific also, but if suppose if it's a transplantric or sphincter involved, probably you might not consider pouch, even if it is UC as well.
Yes,
So it affects your diagnosis also can be affected, or it might even your decision for surgery
Yes,
also might change.
yes, sir.
So what about the rectal examination? Why is that important? Perianal we understood for Crohn's, but
Rectal tone is important. The sphincter tone is important because when we're doing a pouch, sphincter tone is important. If the fecal
it's only
incontinence
tone or
is
something else? Yeah.
sphincter tone, and if there's any mass per rectum, also we can.
Okay. Yeah, but regarding the tone, anything else specifically that you will look for? If you don't say it, that means you don't do it.
We'll ask the patient to squeeze and normal resting tone and.
Yeah, so squeeze pressure is extremely important. Don't underrate it. You must say that squeeze pressure is extremely important. Earlier, 20 years back when pouches started, they actually used to do the rectal function tests and all that. That's practically been given up because squeeze pressure, even despite its subjectivity, is a fantastic surrogate for all those. It's probably just as good as all those in predicting a good outcome, in the retention and all that. Okay, go ahead.
So now I want to review the patient old report if available.
What?
To see what is the colonoscopy and biopsy findings, and what are the medications the patient has taken until now.
So why do you want to know medication the patient has taken?
Because the patient was tried all steroids or biologicals until now.
Suppose he's taken steroids, then what? Suppose he's taken azathioprine, then what? Suppose he's taken biologicals, then what?
If yes, patient was already treated with steroids, if there's a good response, then now also we can again try steroids and see.
Obviously had a good response. Each time he has stopped it himself.
It's a relapse.
Yes, sir.
That's
Last
a
time,
very important sort of examination, the sort of historical
history.
find that each time he has stopped it himself. So remember that do you decide about surgery or does the patient decide?
Both, sir. We should discuss
So
with the
let me
patient.
rephrase that. Suppose the patient says, I'm happy each time taking all this. Does that change your decision for surgery?
Because it's multiple relapse, I think we should advise them surgery from our side.
So you will sell surgery. No, you must not do that. Suppose you have a bad outcome with pouch, he will sue you. No?
Yeah, yes, sir.
You must take the
Patient
patient.
should be counseled. Patient should be counseled.
Yes, sir. Counseled regarding like pros and cons, like if not surgery, the chance of relapses, and with surgery, complications with surgery, and
Yeah,
quality of life after surgery.
in the real world, all these patients are controlled by medical gastroenterologists. So it's not about weaning them off the medical gastroenterologist. You must show them what are the benefits of surgery and whether they choose them or not. An older patient might actually still say, I do not want surgery, even if they've had 8 relapses, 20 relapses during the last 40 years. If they are, so long as they are happy with it, it should affect their, social, economic. So it's a shared decision with them and you when it's none of the specific indications like malignancy or exsanguinating bleed or anything like that. It's a shared decision. Even if it's just malnutrition, you can actually nourish them. You can give them nutritional advice. So be very careful about all chronic disease. It's a lifestyle issue. A decision for surgery, whether it's chronic pancreatitis, it's ulcerative colitis, it is a lifestyle issue. It's a soft indication. We don't have. There are some hard and fast indications like malignancy and all that, but by and large, it's a shared decision after counseling them. So
Okay.
you must make it look like that. And 9 times out of 10, if you appear to be, a friend of the patient, they're more likely to choose surgery and they're more likely to choose you as the surgeon. Go ahead. So what you wanted?
So at this point of time, what is your objective of knowing the investigation? Because some history, the treatment, he didn't continue the treatment properly, right?
Yes,
So
sir.
are we still not interested to know what is the disease, underlying disease before you take any decision? Because why do you jump
Yes, sir.
for surgery now at this point of time? You still do not know.
Yes,
So
sir.
only
First time,
one thing I could understand is this patient is not compliant with the treatment. Probably patient might not have been told about the details of the disease, the importance of continuing medication, right?
Yes, sir.
So that is the only inference I could get. But do you want to know the diagnosis before you take any
Yes, sir.
jump?
Yes, sir. We'll know the colonoscopy report and the biopsy report so that we can see the confirmed diagnosis, what has been made already.
Biopsy means
And
what do you want in biopsy?
like usually in ulcerative colitis, we see cryptitis, cryptapses, and
No. Do we know about this patient's biopsy?
no, sir. I'm telling, sir, we should see for the previous biopsy reports.
Okay.
So
What is the report?
cryptapsis tells you what?
Active infection, active colitis.
Acuity. It tells you the acuity of infection. So how does that change? Will you not get that in Crohn's, for instance? Or will the presence of that change your decision for surgery or diagnosis?
No, sir. And also transmural inflammation or superficial.
How will
These
you get
things
that
and
in a
all.
biopsy? You need a full thickness biopsy to know transmural, isn't it? Will you get that in a mucosal biopsy?
No. In Crohn's, we usually see granulomas.
So that luxury you will get in, for instance, if it is fulminant colitis and he's had a near total colectomy, total abdominal colectomy and you now send this specimen for biopsy, you will get a lot of that information on that. In fact, that's not to be discounted. Sometimes you get a lot of information in that. If you get, all the features suggestive of ulcerative colitis, but when you send that staged specimen, and you find a lot of granulomas in it, you have to consider indeterminate or Crohn's, isn't it?
Yes, sir.
So, but all those features you don't get in a mucosal biopsy, transmural inflammation, and all that. Specifically, what are you looking at is what Dr. Pradeep is asking in the investigations. What are you looking at?
Colonoscopy, we know the extent of involvement or
Extent
where
or okay, contiguity. You
severity.
want to look at contiguity. Is it a single entire thing is involved in one, or are there skip lesions? Isn't it?
Yes,
So
sir.
typically in ulcerative colitis, what will you have in this 29-year-old
We'll
guy
have,
with 6 years? What will you have typically?
we'll have continuity, sir. Mostly
So
left side,
95% will start from the rectum, rectal
left
involvement,
side.
almost sure, which we know.
Yes, sir.
Plus, it will be contiguous to a variable involvement. It may or may not involve pancolitis, but you will microscopic. You need to sample all along because you will have microscopic colitis in the proximal parts also. So that might even change your decision. Then you're looking for random dysplasias and all as well, isn't it? So when
Yes,
you're
sir.
saying biopsy, you should be specific. Don't say transmural in biopsy. We will never get to know that.
So what other investigations were interested in apart from scopy?
Let's come back to this patient. So
Yeah.
what investigations you would like to
Yeah,
know
apart
of the
from
previous, you want to say
Col-
what investigation?
Colonoscopy.
Colonoscopy. Do you have old colonoscopy, Chidanand? Previous colonoscopy report?
Yes, sir. We have the colonoscopy which was done 1 year back, sir.
Okay, can you?
So here the involvement is seen rectum, sigmoid colon, and descending colon. So left side.
One thing you have to see is how much, whether it's a full-length colonoscopy done or not. 9 times out of 10, you will see when in a 6-year-old history is, if it's a 1-year-old, is that they've only done a limited left-sided.
So here they have shown that the transverse colon, hepatic flexure, and cecum are normal, right?
Very important to
Yes,
say
sir.
that the entire scopy is done. Yeah.
Yes, sir. Endoscopy is done, sir, and the involvement of colitis is seen up to the descending colon. So left side colitis.
What else you want to do? So does this colonoscopy findings are in favor of UC?
Yes, sir. Superficial ulceration is there, loss of vascular pattern, and also mucosal bleeds. It's seen in UC, and it's a continuity disease. No skip
What else?
lesion.
What else you want to know? Any
Is
other
there any-
investigation? Go ahead.
No, sir. We usually see pseudopolyps or any
No, this is what the
lesions.
report is. This is what the
Yeah.
report is. What else the next investigation you would like to ask for?
If any biopsy taken during that
Yeah.
time, whether
Biopsy.
acute colitis.
So do you want a biopsy, or what kind of a biopsy would you ask for if you're sitting with the, so the senior was busy with a bleed in the emergency and you get the junior PG there. So he says, can you come along, sir, and tell me what all I'm supposed to do? What all will you tell him?
We'll take the biopsy at the disease site and also the normal areas after that to note colitis, and if there's any
At
mark like
regular,
lesion.
at regular intervals you'll take. You want to look for background changes in the areas which are normal also, and you want to look for dysplasia changes in the area that's there, and the typical changes which of acuity and chronicity. Yeah. Okay.
Yes.
Can you have biopsy report?
No evidence of any granuloma dysplasia malignancy, and cryptapsis and cryptitis is present. So it is a active colitis, moderate active colitis, with no evidence of any granuloma dysplasia malignancy.
So is it acute or chronic or acute and
Acute.
chronic?
It's a chronic, at that point of time, it's a chronic moderate colitis.
Yeah. Dr. T.D. Yadav was asked, we don't know whether he was uncomfortable with medication or any type of side effects. Is that important?
Yes, sir. If any side effects, it's important to
Yeah, that can
to
also
avoid
alter
in
your
future.
your
So
decision.
he has stopped medication. He has stopped medication. So probably he might have stopped medication because of the side effects as well, what Dr. 3D is highlighting.
Yes.
Yes, sir.
So here
We
there
should
is a crypt architecture is distorted. Crypt loss is there.
And cryptitis and cryptapsis formation. And so forth.
So what does it signify?
Acute and chronic, sir. Acute disease also is there because cryptitis and cryptapsis, and loss of architecture is usually significant.
Yeah. So crypt loss is there, signifies it's probably it's a chronic.
Chronic.
On top of that, you have a acute inflammation or okay. What else you want?
Absolutely.
So the acute
Right now,
exacerbation
जो
and chronic issue.
Other-
Okay, go ahead.
Yeah. Any other investigation?
Yes, sir. If any imaging done previously,
What imaging you
What
want?
imaging and why? Why do you want imaging?
uh, in case of acute this thing, imaging helps us to rule out any uh, toxic megacolon these symptoms. Otherwise,
Never say
small
bombastic
bowel.
statements like rule out and all that. Huh? So you can say it can help us to tell.
See,
But in life, if you always say rule out, nothing can rule out anything.
okay,
You're not
Yeah.
interested to know about the hematological
small
investigations
bowel.
before? Blood
Yes,
investigations
sir.
before previous episodes?
Yes, sir. Important. I will like to see the previous blood investigation.
Do you have any previous investigations, Chidan?
No, sir, we don't have any.
No.
So
How to
imaging,
relate it?
imaging
Yeah.
specifically, you said what imaging and why did you want? You haven't told us what imaging.
Yes, sir.
The test, what you were trying to say is a very simple imaging, isn't it?
Ultrasound followed by CT scan, sir.
Ultrasound. What will ultrasound tell you in ulcerative colitis?
Ultrasound can only tell if there's any ascites or not, if the liver is PSC
Ascites.
sometimes.
Yeah, so liver
PSC,
changes liver changes you can know.
apart from that, we can't see anything specific, sir.
So
Then we can
what
CT scan.
specific imaging you
CT.
you won't get a plain X-ray? You do CT
Yes,
to
sir.
look for megacolon and all?
No, sir. Plain X-ray, you can see the
So
diameter
what all
of
can you
colon.
see? What all can you see in a plain X-ray in a case of UC? So don't discount plain X-ray. It's a very useful investigation. It's probably more useful than ultrasound. What all can
We
you
can
know?
see the distance of colon, if it's more than 5 to 6 centimeters, chance of toxic megacolon can be
So he doesn't
considered
have
as when
signs
we
of
free air.
He doesn't have signs of toxicity. He doesn't have distension. So why are we looking for toxic megacolon? So okay, it is one of the best ways to look for megacolon by looking at the diameter on size on that. But before that, is there what all can a plain X-ray help you with? It's a fantastic versatile tool. If you're sitting in a primary health center, you can get a lot of information on that. It can actually tell you disease activity. In a patient like this, you can see the area that you're seeing formed stools is usually uninvolved by acuity. So if you're seeing stools in the right colon and not seeing the left colon with formed stools, it tells you it is left-sided colitis. If the entire descending colon is also filled with stools, it could just be ulcerative proctitis. So it can actually tell you extent. It can tell you presence of obstruction, like you said, perforation, this megacolon.
Free air.
A lot of things it can tell you. Yeah. So don't discount a plain. Very few places now in surgery that a plain X-ray can tell you a lot of stuff. So CT you wanted. Why specifically CT? What are you looking for in CT?
In CT, we can see if there's any small bowel involvement. I mean, if you are not sure about ulcerative colitis, we can see for any small bowel involvement, or we can see any.
So why are you?
thickening of.
So for that, would this be more important, or the biopsy from the ileum which was taken would be more important? See, most of the
Biopsy from the
changes. Yeah, so most of the changes with this kind of history, you're very unlikely. I'm not sure I would keep CT at the top of the level. If there was a mass in the rectum or something, and I want to know what stage, it's extremely important. I'm not sure CT is a very important in a chronic disease where you're going to need these investigations frequently. So you might be doing, you have to be very judicious about how you follow up. When you're counseling them, you need to tell them what all you're doing. So I've had a very top gastroenterologist last month only doing a PET scan for a elderly 70-year-old patient of ulcerative colitis who had the disease to look for CA rectum. 2 PETs were negative and she still had a CA rectum. So a wrong investigation. You can say, I'll follow up an older patient with PET. Absolutely no evidence, completely useless. So don't say investigations. You must be very clear when you're saying an investigation, what you specifically want from that. Yeah?
Yeah. Right now, I want to see the patient blood
So if
in
you're
at
looking for
point of time.
So if you're looking for Crohn's, you need a specific CT enterography.
CT enterography.
Yeah, so that's a different from the usual garden variety of CT that we do. So if you're looking for that, you need, so if you're getting any clues as of say granuloma or history of obstruction or anything to suggest that, here everything is typical. Yeah, so
Okay,
it's
Banu, these are the old investigations which was done before. You had a colon, left-sided colitis, and the biopsy is confirmed.
Yes,
So
sir.
now this is the patient who has come to you right now.
I
So
want to
now,
first.
how do you proceed now? And from with this background history, with background whatever old investigations, and the patient has come back to you now.
I want to do the hemogram first, sir, to see for the hemoglobin level, and followed by LFT to see for albumin and bilirubin level, and electrolytes also to look for any dyselectrolytemia
albumin
because of
and
dehydration.
bilirubin level. So you know your investigations that you say will tell us what is your importance in all this.
ALP, yes, sir. In hemoglobin is very important because pallor is also there and bloody diarrhea is there. So based on the hemoglobin, if we can see if it should be treated or corrected.
So
For
either you say it in a logical manner, so we know that you have a, or you say it in the order of importance. So since you're saying it random, please say, like you said, hemoglobin and albumin would be very, very important in this particular case, isn't it?
Any
All the
other, any other, any other thing? Yes, sir, is important in this.
yes, sir, ESR and CRP
Why?
to see
Why?
for the severity of disease, where is it, if it's more than, and to
activity.
see, yes, sir, activity of disease. If it is more than 30, 35, the severity is usually
Can we
considered.
have the investigations?
Hemoglobin is 8, sir. Counts are 13,000 on the higher side. Hemoglobin
ESR?
8.1. No need to correct it.
Any ESR report?
ESR is 36, sir. Higher on the higher level only. And I want to see the LFT values also, electrolytes and LFT also. Bilirubin is normal.
Go for it. LFT. Yeah.
Albumin is 3.1, sir. On the lower side, 3.1. INR is normal. Bilirubin is normal. ALP is also normal.
You've been very worried about PSC all through. How does it impact?
PSC doesn't change the management of colitis, but PSC as such.
No, as a surgeon, you are very extremely worried. So tell me how all it can actually alter your thing. One you said was malignancy itself. What else?
PSC requires usually liver transplant if it.
But that you'll get features of end-stage liver disease historically, yeah? None of those are there. Why would you want to know? How else can it affect your decision as a surgeon? So you're looking for surreptitious PSC, isn't it? How
Yes,
will
sir.
that change your management? So not about transplant, but you might have a high grade of portal hypertension, which might make your surgery difficult. That's the only thing, because you said that in every form you were worried about the alk-phos, knowing the ultrasound to look for PSC and all that. Most changes you don't get in ultrasound. I think next you would have almost done a liver biopsy as well to look for PSC. So those are the only two ways that it can actually alter your treatment. Huh? Okay, go ahead. What else?
Next investigations. Renal function is there?
Yes, sir.
Yeah.
Creatinine is normal, sir. Electrolytes, sodium, potassium also. Potassium is slightly higher, but.
Okay, next, what do you want to do now?
What is the low urea creatinine? What can it give you a clue to? How many were worried about high? Yeah, so high can be dehydration or renal failure.
Fluid retention.
So low is usually malnourishment itself. You're not anabolic.
Protein loss.
So be careful about doing surgery like a pouch and all that. You might have to alter your decision to actually stage the disease. Okay, go ahead. Electrolytes also, because if you're seeing huge electrolyte fluxes, you need to be careful, correct all that, and then go ahead with major elective surgery. Okay, what else? Other bloods? Anything else?
Now, what do you want to do?
So right now, patient hemoglobin is 8, sir. No need to correct it. Albumin is 3.1. Nutrition status is a little poor. So if possible, we can do a
If possible, we can do a.
Yeah, we can do many things. The
Sigma.
question is what you want to do. You are the treating surgeon. So the patient has come to you with the back, he has shown you the reports, you got this test done, and these are the results of the test. What's your next step? How will you proceed?
I want to see what medication he's taking right now, whether we can, based
Do
on
you have
that,
any
whether we can.
history? Siddharth,
You
do
know
you
the
have
history,
any?
no? So what all? What
Yes,
are the
steroids,
potential
he has taken
changes?
steroids.
Yeah. So what are the potential changes you can do? There's a possible history. Two bloods, two injections, 2 weeks apart. So possible biologicals. He has tapered them himself. So what all do you want to change? Just for medical management, what all would you like to do?
Sir, during those 2 episodes of biologicals, the patient actually responded, but there was no complete resolution of symptoms at the point of time. Whether
But
we can discuss with the patient and medical gastro
somebody
unit
who's
whether
somebody who's on steroids and getting improvement, what change would you like to make as a for the medical management?
no, sir. I mean, now right now his symptoms are severe, so whether we should try one more IV injectables at this point of time
Are
to
you
make the disease.
are you keen on that? So are you worried about the long term or just the short term? So you need to discuss all that with the patient before deciding, isn't it? So
Yes,
generally
sir.
for steroid sparing, you'll push towards AZA and all that, azathioprine and all that, so because they can help you manage especially since he has sharp remissions and only 6 episodes in the last 6 years or whatever. Yeah.
Banu, don't you want
Yes,
to
sir.
evaluate the status of the colon now? Because the colonoscopy was about a year old.
1 year back.
So do we know don't you want to know the status of the colon right now? Because how can you take a decision on the treatment?
Yes, sir. We should do a full-length colonoscopy can be done now. I would like to do a
Now,
full-length
is your
colonoscopy.
patient in acute ulcerative colitis? Is it acute severe or it's moderate?
Moderate,
Based
moderate severe, sir. Not fulminant or toxic
not
megacolon.
fulminant. Okay.
So we can do a colonoscopy.
Can do. I mean,
So we will do a colonoscopy to look for the
You should
why
be very
specific,
decisive.
why specifically do you want to do? Within a year, why would you want to do a full length? What has changed in
we
this?
can see the progression of disease and extension, whether it is extended to the other side or not. I mean,
It's to
extended
satisfy your
beyond the left side
curiosity.
colitis.
It's to satisfy your curiosity, or you're looking for something specific?
We'll see the extent of disease, whether it's extended beyond the left side colitis as mentioned
Will
before.
that change anything? Now it's extended up to the transverse colon, to the splenic flexure, or to the transverse colon. How does it make a difference? So one thing is that he's
We
had
can
that
counsel
change of those. So correlated with the history in this patient, he's had
This
those
patient, yeah.
changes of weight
tenesmus
loss.
and urgency
Yeah.
is there.
Yeah.
You
So
specifically want to do a flexi-sig for sure. You want to make sure that there's no new malignancy. The extent and all we've already decided. The rest of it, all management you're going to see based on is very, very unlikely. It's possible. I've seen lots of patients that you have discrete areas of dysplasia, but very, very unlikely, isn't it? You need to take a decision whether to continue with medical management or surgery based on history and this part of the thing.
endoscope.
So the only thing will change is only so probably you
They
don't
say
need to
mass.
do a full length. Yeah.
Okay, do you have a colonoscopy?
There is no. I mean, it's a pancolitis picture, sir. Ileum is not mentioned here, but up to hepatic pressure ascending colon cecum is normal.
Is there anything paradox in this report? Can you read the report and say that?
Pancolitis.
They have written as
We can't
pancolitis,
because it's only there up to the
but they
descending
have
colon and
mentioned
transverse colon. Whether it is if it is beyond the mid transverse colon, I
So
think we may
by
have to call as
pancolitis,
pancolitis.
Yeah, we want cecum also involved. Okay, go ahead. What else do you want?
There's no any mass or anything in the rectum, so that we can, I mean, malignancy is.
Next investigation, what do you want? Or you've decided, or you can, decide what you want to do.
Yes, sir. Now we can uh, discuss with the patient, multidisciplinary with gastromedicine
You
team
don't want
also.
biopsy now? You don't want biopsy now?
Yes, sir.
These cases?
Biopsy will give the
So because there
activity
was a
of disease
discussion
right
about
now.
dysplasias and all, no? Dysplasia and all.
Yes, sir. Biopsy will help to rule out any dysplasia or any malignancy
Yeah.
at this point of time also.
So even though you don't have any malignancy, but still you need to do biopsies to rule out any dysplasias. Okay.
How will
So
dysplasia change your management?
If it's a dysplasia, then we should plan for surgery. There's no, we
No,
can't wait for
you need to know the type, the grade of dysplasia. Is it low grade
low, yeah,
dysplasia, high grade dysplasia? Low grade dysplasia
low
needs
grade
surveillance.
dysplasia. Yes,
High grade
yes,
dysplasia, you can check medical management, recheck to see whether it's progress,
high grade.
it's still high grade or downgrading or not. Otherwise, it's a stronger indication for surgery. Yeah. So high grade dysplasia is especially at least few months apart. Persistent high grade dysplasia could be because you're likely to miss a malignancy. Okay, since we're reaching towards very close to the end. What do you want to do? Let's not keep on saying investigate, so that you need to know what are important. I think you got enough information. What do you want to do now? So like you said, absolutely true, Bhanu, that you will here it's very, very crucial to discuss all the options with the patient. So what would you sell, that if I was the patient, what would I do?
Okay, sir, I would explain and give the option of surgery because the patient had relapses and with history of moderate to severe intensity,
You're
also
so,
requiring
so
IV.
unsure he's not going to choose. The medical gastroenterologist tell oh, we can avoid surgery and all that. You have to be very clear what all you're going to tell him.
do you want to try medical treatment or you want to go for surgery?
First, right now, I want to first optimize the patient and then give the option, I mean, plan for surgery, so electively.
So what is the
Not an
question?
emergency.
What is the question?
Whether you want to give medical management or surgical.
Yeah, so you haven't answered that.
Surgical management, but after optimization of.
So this is one time that you can have the option of giving unlimited, but you want to take a call whether you need to take surgery or not. So you can take a call to do continued medical management. However, I feel that surgery might be better, isn't it? Why?
Yes, yes.
Why? You need to tell the patient, why do you think surgery might be a better idea?
Because it's already been 6 years, and with more than 8 to 10 years, the chance of malignancy also is higher. And
So don't
apart
sell
from that,
malignancy first. That's exactly, all of you do this in the field, and that's how you get into problems. The patient runs away when the physician tells you that the risk of malignancy is only this much. Every single senior physician, even date, says in India, I show them the data and they say in India it's very rare to have. Oh, but I don't get to see any of these patients with malignancy. So they actually don't believe it, and they will convince the patient. So do not start with malignancy.
The frequent relapses are there, which for which
Surgery
patient has
has
to take
the
lifelong.
So you must be
Curative.
very clear.
Curative.
Surgery
Surgery
has
can
the
be
potential.
curative.
Has the potential to be curative. We want to avoid it as far as possible. If it can, a certain proportion of cases are fantastically managed with medical treatment alone. You seem to be escaping that. Surgery is going to cure. It does carry a bit of baggage, but in your case, it might be the best option. If you're the patient, won't you listen to that? You scare them, gallstones, we will get malignancy if you don't operate. He reads the actual data and says, no, this guy's just trying to get me onto the operating table, no?
Bhanu, I might see if you offer surgery, I want you the reasons why you choose surgery also is important, right? Because if I ask me, I will say I will go for medical treatment. I can have justification, right? I say this patient is young patient, not yet married. Second, he did not take the medicines as suggested probably by this, right? So now he is in the not a severe form, but mild. It's not mild. It is moderately severe form of these things. I can put the patient on a medical treatment and see the response to the medical treatment before I decide for surgery. Am I right
Because
or
already,
wrong?
right, sir. My
Would you call him
my thing,
non-compliant? What
yes,
Pradeep
my
is trying
thing
to
is,
say to you?
yes, sir. He is
Actually,
non-compliant,
he's
so
not. He's not. He's been compliant.
I
He's
don't
only
know whether he
stopped.
has been told
Yeah,
importance
he's
of
been.
continuing medical treatment. As Dr. T.D. Yadav also pointed out, probably must have stopped because he developed some sort of a reaction. We don't know this history.
okay.
So why do you
So,
jump? And that too, the disease is mainly confined to the left colon as per the report. So why should we jump right now? That's not my argument. Now you should defend your statement.
because surgery is potentially curative, and also patient, uh, whether it's non-compliant or not, as you told, but he had stopped medications in between, like for 2 to 3 times, and he had relapses episode. Now he's little more severe compared to the before. Uh, at the starting also he had 6 to 8 episodes, but it's little more severe now,
So
8
that
to 10.
means you don't want to start the medical treatment at all.
No,
Straight
sir.
away counsel him for surgery.
No, I will optimize the patient first with medical treatment. Will decrease the severity of the disease.
What do you
If
mean by
it's
optimize?
nutritionally,
Okay.
nutritional, and also uh,
But
now
that's
the
not
patient having
treatment for UC, right?
moderate to severe colitis is there. So we'll treat with either with biologicals or steroids and see the response.
You speak,
Uh,
be
and
specific. You want to do steroids or biologics. Don't be this thing. You have to do one. So you
biologic.
want to straight, you want to go biologics.
So you see, each time with all these, he's got the relapse. What is his? What is the flaw in the treatment? He has stopped it on his own. So what does that tell you? He's not been taking
Not
preventive treatment.
counseling.
No, he's not been taking preventive treatment.
Treatment,
So
yeah.
somebody, you can, the aminosalicylates and the the immunosuppressives can actually reduce the number of episodes you can get.
Maintenance.
So he might still be a good, he might be still a good option for medical management, continued medical management. If after he's had the relapse, he continues with the either ASA, or if he's on repeated steroids with azathioprine and all that. So he might still have an option. Don't make it out as if it's a surgery only because it's only 6 years. So we start getting worried beyond 10 years or so for all your malignancy and features. The actual risk of malignancy less than 10 years is low. Yeah, so that should not
now
be, unless you have features of dysplasia or something like that. So do not sell it only for surgery. He may not have had, what Pradeep is saying is absolutely true. He may not have had. You see, he stopped it himself by trying to give you a clue lots of times. So he might actually have a fantastic. Does 5-ASA make a difference in the number of relapses or no?
yes, it makes it helps
Yeah,
in
it reduces
reducing
the
the
number of.
remissions.
Yeah, it reduces the
Relapses.
number of times that you relapse. What about steroids? Does that change that?
Steroids usually in induction we use, sir. Induction
So
maintenance is
steroids
not.
and biologicals are only for managing that particular thing,
Sure.
In
So now
Crohn's,
with the
So
patient,
while counseling,
yeah.
so while
Go ahead.
counseling the patient, I would tell him regarding the importance of continuing the medical management properly without stoppage, and see whether patient is having any relapses after that also. If the patient is having good response to medical management and no relapses, then I think surgery might not be can wait. Surgery can wait for now. And, but I'll explain about the surgery option also and give uh, uh, pros and cons
Bhanu,
of surgery so that you can understand.
Bhanu, the present treatment of an acute exacerbation, unless there's a perforation or a complication, the first
medical.
option is always a medical treatment,
Yes, sir.
right? And see the response, because we don't want to operate a patient in an acute scenario,
Yes, sir.
right? You might convert into a, suppose he responds to it, then frequent relapses, then you might consider surgery at an elective scenario.
Later date.
But in an acute scenario, the first option is always
It's always IV.
steroids, right?
Or biological.
Your patient might respond, might not respond. That's a different story. So if it doesn't respond to therapy, you might have option of a biologic, adding a biologics, and still doesn't respond, then probably surgery is accepted.
Yes, sir. First option would be medical this thing, hospitalization with and
So you
IV.
don't operate, there's no emergency indication in this patient, because in this patient, is there any
Severity
emergency
is not
indication that
no, sir. No, not fulminant or not toxic megacolon. So no need indication for emergency surgery. So I would give IV steroids and see if there was a response. If not responding, we can add
Suppose we say
biologicals and
patient
see.
is response. Now let us take, okay, we started steroids, patient has responded. His stool frequency has come down to 2, blood has stopped. So what is your course of action now?
I'll change the steroids into the maintenance drugs, 5-SA or thiopurines as a maintenance dose, and will counsel the patient regarding continuation of medical management. Yes, sir. We'll try the maintenance course of medicines, 5-SA or thiopurines.
Okay, I'll give the background of this history. This patient, the medical gastroenterologist, started IV steroids for 6 days or 7 days, and he did not respond. He continues to have. Otherwise, he is able to eat, no fever, nothing, but the frequency of stools continued to be 7 to 8, even after a week of steroids. Now,
we can add biological and see for the response. Usually, if not respond to steroids, usually by 4th or 5th day, by the end of 3 days, we know the response to steroids. If not responding, we can add biologicals by 3rd or 4th day and see.
Any other super added things can develop in these patients where you can
Infection,
produce diarrhea?
Clostridium difficile and CMV has to be ruled out by doing
So can you have a report of
examination.
that? It was positive for CMV.
Yes, sir. It can CMV. We should rule
What
out.
should I do now?
Give ganciclovir injection treatment for
Okay.
CMV. See the quantity.
Yeah, go ahead. Go ahead.
See the quantitative CMV also, and ganciclovir treatment should be given for the patient. And immunosuppression, I think we have to right now decrease it if possible. If he's on steroids or.
So you would like to add ganciclovir now?
Yes, sir.
Okay. Ganciclovir was given to this patient, and still the patient did not respond. He continues to have 7 to 8 motions, and still blood stain stools. So no response to steroids. And after ganciclovir. Okay, go ahead.
Rule out Clostridium difficile Pradeep infection also.
Negative.
Then I think we should plan for, if not responding to medical management and ganciclovir also, then we have to plan for, we should plan for emergency colectomy.
There's a question called role of foam or enemas if CMV was not positive.
Yes.
Not responding to steroids.
Local steroids.
So if it's
Yes,
pure,
sir.
it's proctitis particularly, or even for some varieties of left-sided colitis, there is
Left-side colitis.
Yeah.
Yes, sir.
You can give a relative
Enemas
sparing. What enema will you give?
5-SA enema, or we can give budesonide enema also.
Steroid enemas.
Steroid enema.
By and large, if it is a disease confined to the rectum, suppositories will do.
Suppositories, sir. Yes, sir.
If the disease goes beyond into the left colon, probably enemas. Okay. So now you have a patient, you have tried the steroids, you have found it is CMV, also you treated it, no response. So you have the option of now what do you want? You want to go for surgery, or you want to change your medical management?
I think surgery, sir. Surgery. Emergency surgery.
So you would like to. So the physician might say, okay, I can still manage medically. So what is his option now?
Biologicals.
So there's option for biologics. So all these decisions have to be discussed with the patient. It's not the surgeon who decides, because, right?
Yes,
that's what
Patient
Puneet was trying to say. Patient should be involved in
shared
the decision.
decision.
Yeah.
I think
Okay.
should we involve the other panelists?
Yeah. So should we decide? Suppose you decide for surgery. What surgery are you going to plan now?
Subtotal colectomy and endoleostomy would be better here.
So will you discuss the surgical options also with the patient or not?
Yes, sir. We'll discuss the options, but here, because the patient is having severe colitis, and
What are the
trans-
various surgical options for ulcerative colitis?
ulcerative colitis in general, three-stage operation where we first do total colectomy and ileostomy, followed by ileoanal pouch, second stage ileoanal pouch anastomosis with diversion stoma, and followed by reversal stoma. That is three stage. Then is two stage, where we do ileal pouch channel anastomosis in the first sitting with diversion ileostomy and do the reversal after that. And there is one more thing called modified two-stage operation, where we do total colectomy and ileostomy in the first stage, and then we do the ileoanal pouch anastomosis without diversion stoma in the second stage. That is being preferred in case of severe severe colitis or high-risk patients to decrease the number of operations. And one stage is little rare, it's very selectively done, one-stage operation.
Pouch is the only option?
No, sir. In end ileostomy or ileorectal, some very very young patients who has not completed
No,
their.
this patient. Ileorectal are you planning ileorectal in this patient?
No, sir, no.
In this patient, you have to
Ileostomy.
counsel.
End ileostomy, sir.
End ileostomy is not a surgery, no?
Not an operation, no? It's not the
No,
treatment.
colectomy plus.
Total proctocolectomy.
Total
Yes, sir.
proctocolectomy. So you should discuss all these options with the patient.
Yes, sir.
Pouch is one of the options. Pouch can be done in single stage, two stage, three stage, whatever you want. That's a different issue altogether.
Here, in this patient, I would prefer to do total proctocolectomy with end ileostomy.
Total proctocolectomy with ileostomy.
Total colectomy with end ileostomy.
I didn't
You
get
mean
what you
Inpatient. Total.
You're talking about staging it with total. When you
Yes,
say
sir.
total colectomy with end ileostomy, we don't know what you've done, isn't it?
What your meaning?
Staging followed by then proctectomy can be planned later. Second stage.
So what do you do with the rectal stump?
We can bring out. I'll bring out as a mucus fistula, sir, because high chance of.
So it's not clear. When you say total colectomy, end ileostomy, we don't know what you mean. So if you say
Mucus fistula.
what you did with that, yeah, okay. So why not do a Hartmann?
Stump blowout chance is high because already proctitis active disease is there.
How long are you going to wait for the second stage?
In this patient, because it's a young patient, unmarried, I think we can wait until after discussion with patient, if they want us to wait, we can wait until the family is planned and this thing, then we can plan for.
Suppose he says, I don't want to have kids at all. Are you deciding his? So all that is part of the discussion, isn't it? If a guy is adamant that I don't want any family.
Family.
Is it only family or there's something else also we're worried about?
Disease also. Disease.
What
control of disease.
What
complications?
29-year-old
male patient in a male patient.
Somebody who doesn't want children but still wants something else.
Erectile.
Importance. You have to tell him that there's a potential for that. It's very low and
4%.
Centers. Yeah. So okay, I think should we involve the other any of the other?
Yeah, other faculties. Dr. Shastri, Dr. TD, Dr.
Please unmute. Meanwhile, they unmute. There's a request, Pradeep, from an anonymous attendee. Can the AIG team upload videos of these classes as exams are fast approaching? So they want to use.
Sorry. I apologize because a lot of things have to tidy up those videos and then upload it. I'll do it off. Anyway, a lot of requests came. I'll do that.
The second question they've written is total proctocolectomy and pan proctocolectomy, the one same thing. Yes, Jasmeet, they're one and the same thing. It's implying complete extirpation of the colon and rectum and end ileostomy, a permanent end ileostomy. Cox, continent, and all those are no longer done, I think, anywhere in the world, except as a conversion in somebody who's already got end ileostomy and wants a potential to do it. The only soft indication, hardly anybody does it now.
Yes. Dr. Shastri,
Jaswant.
Jaswant.
Yeah, I think the candidate is okay, very well. He did appear temporarily rattled by continuous bombardment, but he did show an open mind. accepting the given alternatives. I think which is a very important thing at this stage. So what he should realize is when you have so many options, counseling plays a lot of role, particularly in, you should try to know why he had stopped maintenance treatment, apart from suggesting what is to be done. And you should suggest that he has a high chance of ending up in surgery, although it may not be immediate. So sort of preparing him for the alternatives which you have in mind. Keeping in mind the long-standing surgery, the multiple episodes of pulmonary colitis, although he had responded to treatment. So this kind of judgment from the patient's point of view also you should emphasize to him and let him take a call on the options. I think this should be the lesson for the candidate.
Absolutely. I think that's a very, very important point that Dr. Shastri said, because you could convert potentially, even though you convince him for surgery, you might convert from a 3-stage to a 2-stage, a regular 2-stage. That potential, if he's convinced that he needs surgery, but get optimal medical management right now, convert an emergency to an elective option. You would be happier with that, because the problem is when we start doing stage procedures, some of them have a bad outcome, and that the physicians again convinced that it's a wish-fulfilling prophecy. They think surgery is bad, so when we do it on bad patients, we're going to get bad results. So if we can optimize it in the same patients who need it at a better timing, we can get better results.
Yes. TD.
Yes. Good morning, sir.
Good morning.
My only point is he's a very highly educated person, and in spite of that, he has not been compliant to the medicine. So it comes to the surgery part also, and that's why he needs very proper counseling, and each and every step to be discussed very thoroughly, because same person with the surgery is also not that easy in this particular group of the patient, and outcome also, even if you make a pouch, the number of frequencies going to have in the when ileostomy closed. So all because even surgery is not panacea. So surgeries also have so many problems in the follow-up period. So I think he needs very proper counseling, and the candidate has the medical part he has been able to answer, and moderators have done. But I think this psychomotor changes in a patient of ulcerative colitis and even in Crohn's is very important to be taken care of.
Okay, sir.
We lost you, TD. Yeah. So very important message. Not sure he's completely non-compliant. I think he was not when counseled by the medical team that you need to continue maintenance. I think what maintenance treatment rather than that, his stopping has been justified by not getting a remission instantly. So obviously he's taken a good decision, probably where the physician has not been putting him. So I think it's that maintenance part which is very, very important, which we as surgeons don't realize it.
Yeah. Dr. Jaswant? Dr. Jaswant, are you there?
I think in spirit.
Yeah. Okay. So shall we wind up then? Thank you, Puneet. Thank you, Venkatrami Reddy, and thank you, Dr. Shastri, TD, and other faculty as well. Thank you, Banu. All the best.
Thank you so much. Thank you so much, sir. Thank you so much.